Great, thank you very much, and it's a pleasure to be here today. So, yeah, I'm just going to go over some of the epidemiological evidence, starting off with some intake data. So this is added sugar intake data from across the U.S., and this is based on NHANES survey data. This is a national survey that's of dietary intake across the U.S. And basically what we can see here is that 13% of U.S. daily energy intake comes from added sugar. The title here says added and free, but it's actually really added sugar in this case. And we can see that this amount sort of differs by gender and also by age group. And we can see some very high intake levels in children and adolescents, which is of great concern. And this data is actually, these data can be found on the USDA 2015 dietary guidelines. This is actually a figure from the new dietary guidelines. And so looking at the sources of added sugar, so this is also from NHANES data and was presented as part of the updated dietary guidelines, we can see that the majority, so about 47% of daily added sugar intake is coming from sugar-sweetened beverages. And it's broken out, if you can see in the little rectangle there, and a majority of that is really soft drinks and fruit drinks. So 47% of daily added sugar intake is coming from beverages, sugary beverages, with a majority coming from soft drinks and fruit drinks. And so a number of studies have looked at the relationship between intake of sugar-sweetened beverages and disease outcomes. And the real focus has been on sugar-sweetened beverages for a couple of reasons. One, it's the greatest source of added sugar intake in the diet, and two, it's somewhat easy to measure based on the dietary assessment tools that are available and the nutrient databases that are available. Some of the nutrient databases don't actually include added sugar, so it's been a little bit challenging to study. So the majority of the evidence thus far has focused on intake of sugar-sweetened beverages. And now this is a meta-analysis looking at studies that have evaluated the intake of sugar-sweetened beverages in relation to type 2 diabetes from prospective cohort studies. So in this field, when you're looking at the relationship between diet and clinical outcomes, we really turn to the observational data, because trials, which is really, has been the gold standard in many fields, they're difficult to do in the setting of nutritional epidemiology when you need years of follow-up to look at the onset of disease outcomes. So for these questions of interest, we really look at the prospective cohort data. And so here we have a meta-analysis of studies looking at the relationship between sugar-sweetened beverage intake and diabetes, and we can see that there's an 18% increased risk of diabetes per increment of sugar-sweetened beverage intake. And so similarly, there's been a recent meta-analysis published looking at the relationship between sugar-sweetened beverages and risk of cardiovascular disease, again, from prospective cohort studies. And this is broken down by stroke, by heart attack, so by MI, and then a composite variable called vascular events, which includes MI and stroke and other vascular events, which was reported in one study. We can see overall there's a 13% increased risk of all cardiovascular disease per 1 serving per day increment in sugar-sweetened beverages. When we look by actual individual disease outcomes, we can see 13% increased risk of stroke, but that's really driven by findings in women, not in men. And then we can see a 22% increased risk in MI, and then there's no association reported there in the study that looked at vascular events. I want to just make a note, when looking at meta-analyses, which is being increasingly done in nutrition, and it was actually, meta-analyses are used to guide the dietary guidelines, it's really important to be aware and to know the individual studies that are included in the meta-analysis, because not all studies are created the same. Some studies are much larger than other studies, are accounting for different covariates, for example, that should be considered. So there's a lot of variability or heterogeneity across the different studies, and that's really important to look at when looking at the meta-analyses. And so this is now a study that was conducted based on NHANES mortality-linked data, looking at the relationship between sugar-sweetened beverages and cardiovascular disease mortality. So actually looking at added sugar intake and cardiovascular disease mortality. So this is one of the few studies out there that have actually looked at added sugars as a whole. And we can see that they're in the fully adjusted model, the second row there, there's a over twofold increased risk of cardiovascular disease death, comparing the highest quintile of intake to the lowest quintiles, the highest quintile being greater than 21.3% of energy from added sugar intake, compared to the lowest quintile, which is from 0 to less than 10% of total energy. And this same study also looked at sugar-sweetened beverages, and there was about a 32% increased risk of cardiovascular disease, comparing the highest to lowest category of sugar-sweetened beverages. So now the biological mechanisms linking sugar-sweetened beverage intake to cardiovascular health is really starting to emerge, and there are really a number of different pathways. So something I want to mention that's been a little bit of a controversy in the evidence is whether or not these studies should adjust for total energy intake and BMI when you're looking at the relationship between sugar-sweetened beverages and diabetes and cardiovascular disease, because BMI and total energy are on the intermediate pathway, so when you adjust for them, associations will be attenuated. And this has been a little bit of an argument that's gone back and forth. Industry-sponsored studies have, for example, chosen to use adjusted estimates, which would have attenuated associations. So there's a little bit of that. So it's also another thing to be aware of when looking at the individual studies. Well, did they adjust for total energy intake and BMI? Because that's going to impact the results. So just what I want to draw your attention to is there's a number of biological mechanisms. One, the link through adiposity, this idea of liquid sugars being less satiating than solid calories from sugar, linking to weight gain. And then there's independent of the association with weight. Sugar-sweetened beverages are thought to be linked to cardiovascular outcomes through glycemic effects, so increasing blood sugar, and then also independently through metabolic effects of fructose. Fructose is the only sugar known to raise uric acid. It's processed, it's metabolized in the liver, which increases triglycerides. So there's a number of different mechanisms that are working together that can result in this increased risk. And I'm sure in years to come, we're going to see another pathway here with the gut microflora. So this is, as Bill mentioned, this is an area of very active research. Thank you.
Thank you. We have 3 minutes for questions.
Yeah.
Vasanti, I never understood in an epidemiology paper when they say, they just give me a number and say the heterogeneity was, and it means nothing to me as a non-epidemiologist. Exactly how are they indexing? What's the measure?
Right, so let's look at a meta-analysis here. So heterogeneity is, in meta-analysis, this is used to assess the between-study difference. And so it's being quantified by something called an I-squared. And when you have an I-squared value of greater than 50%, for example, you can assume that there's moderate heterogeneity. So the studies are quite different. It's kind of similar to this idea of effect modification in epidemiology. If you see different associations, say, in men and women, does it make sense to combine the data and give an overall estimate? So that's kind of what it's trying to do. What it's saying to you is the studies in this overall estimate, the summarized estimate, are quite different.
So the higher the number, the less sense it made to combine them?
Yeah, exactly. When you see a study there with reported and a meta-analysis and it has 90% I-squared value of 90% or 80%, which you see, well, you should raise an eyebrow because you're like, well, how meaningful is that estimate? And then you would hope to see in that study the authors go into exploring sources of heterogeneity. That's another integral part of a meta-analysis. I would be very suspicious if authors didn't try to explain potential sources of heterogeneity. Yep.
I know a lot of studies.
Can you use the mic?
Yes. Why, yes, I can. Thank you. I know a lot of studies have to control for a lot of demographic variables, but then we lose the differences between population groups, and I wonder if there's much data that tells us the effects by different population groups.
Yeah, so that's an important question. So it depends on what population you're looking at. Some populations, large populations, you're able to stratify the data and look at subpopulations, but you really need to have a large data set in order to look at that. And you also need to have a data set that has sufficient numbers of people with those different characteristics. Like in the nurses' health study and the health professionals follow-up study, the two large cohort studies at Harvard that are primarily health professionals, they're largely white health professionals for the most part. So there isn't the opportunity to really look at ethnic differences. We do a little bit, we try, but and the nurses' health study too, which is a younger, more recent cohort, we're able to do that a little bit more. But in the original nurses' health study, there isn't the diversity in order to look at that. But some studies, if there's sufficient numbers of the subgroups, you can.